I think it's 11 o'clock. This is Dr. Luke Evnen. I'd like to welcome all of our participants today. As I've mentioned in the past, but just to refresh everyone's memory, I'm the chairman of the Scleroderma Research Foundation. I'm also a scleroderma patient myself. The Scleroderma Research Foundation, the SRF, is America's leading nonprofit investor in research to find improved therapies and a cure for scleroderma patients. Today, we're webcasting from San Francisco with our guest presenter joining us from the Scleroderma Center at Johns Hopkins University in Baltimore. The SRF is really proud to have been supporters of that center for many years now. The center at Johns Hopkins has really established itself as a hub of both basic and translational research in scleroderma. This is the fourth in our webinar series. Previous presentations can be viewed on our website, which is sclerodermaresearch.org. Also, it's very important to us that we're delivering the content that you want. So please, share your thoughts via email or calling our office. And of course, we also very much appreciate, and in the end, totally depend on your financial support. Medical research is time-consuming and unfortunately very expensive. This webinar is offered to you at no cost, and we do not charge a membership fee. We receive no government funding as well, so please consider making a donation at the end of our time together today. The mission at the SRF is to fund research. We believe that's the best way to help patients. Towards that end, by the end of April, we'll be issuing awards for more than $1 million in scleroderma research. I want to thank all the donors on the phone. We could not do this without you. Today, our webinar will focus on how scleroderma affects our bodies with a specific emphasis on an organ critically affected by the disease, the blood vessel. We'll explore the signature scleroderma symptom of Raynaud's, and we'll also take a look at some of the other vascular aspects of the disease. And we'll take a fairly comprehensive look from signs and symptoms all the way through to treatment and other disease management tools. We're scheduled for about an hour together, and within that time, we'll include a question and answer session at the end. Questions can be asked at any time, although we'll field them at the end using the chat box in the conference window. I should just emphasize that our webinars are for general information only. No information that we provide today is to be considered personal medical advice. And accordingly, we will not be able to answer questions that pertain to any individual symptoms. Scleroderma affects everyone differently, and of course, patients are encouraged to seek care from a specialist. I just do want to take a second out. Some of the images that we'll show today on some of the slides are relatively graphic, so please be prepared for that. With that said, it is great to be able to introduce one of the nation's leading physicians in scleroderma treatment and an invaluable colleague to everyone in the research community and to the SRF itself. Dr. Fred Wigley is a professor of medicine and the founder and director of the Johns Hopkins Scleroderma Center. He is a physician scientist leading one of the nation's preeminent centers. Dr. Wigley's research focuses on the events that cause scleroderma and, of course, its signs and symptoms. He is at the forefront in testing new treatments for both Raynaud's and for many of the other aspects of scleroderma. Under Dr. Wigley's direction, the Hopkins Center has attracted more than 2,000 patients from all over the world and sees more than 300 new patients a year. Currently, more than a dozen scleroderma research studies are taking place with collaborations at other prestigious institutions for which Dr. Wigley's team provides counsel, tissue, and a variety of other services. Dr. Wigley is a compassionate physician with a unique understanding of scleroderma's many challenges. We welcome him today to present Scleroderma, a Vascular Disease. Thank you for being with us today, Fred.
Thank you for having me. The word scleroderma, of course, focuses on the skin disease and means hard skin. But what I'd like to do today is to have us look at some of the other biological processes that may lead to the skin manifestations that are so obvious at the bedside examination. So the goals of this lecture are to focus on the vascular disease that is so important in the pathogenesis of scleroderma. This slide outlines my disclosures. There will be drugs that I speak about that are not approved for the treatment of the vascular disease. When you look at a cartoon of a patient that has scleroderma, you can see that at the bedside there are many manifestations of vascular disease that are obvious by just physical examination. The first, of course, is the Raynaud Phenomenon. But more occult are vascular changes in the kidney, in the lung, in the heart. The gastrointestinal dysfunction is, we think, primarily caused by a vascular insult. And men that have scleroderma often have erectile dysfunction. The manifestations of the peripheral vascular disease is seen and outlined on this slide. There are really four major manifestations that we deal with. The first is vasoreactivity, which we see in Raynaud's phenomena. The second is small vessel capillary changes that are typical of the vascular disease seen in scleroderma. And the third is microvascular occlusive events that cause painful ulcerations. And then less common, but certainly a major issue, is macrovascular disease that leads to catastrophic events in the periphery, even loss of digits as shown on this slide. To bring us a review of Raynaud's, this is a photograph taken of Dr. Raynaud, who, when he was a medical student in 1862, was the first to describe this phenomena. And he recognized, even in those early years, that some patients suffered extensive changes with gangrene, while other individuals, it was an annoyance, but not clinically catastrophic. And since that description of the vasoreactivity of the peripheral circulation to the environment and cold, we have called this phenomena Raynaud's phenomena. And just to remind everyone what it looks like clinically, the one slide of the white fingers, you see that the patient has severe pallor where there is demarcation right at the knuckles across all of the fingers. This occurring on cold exposure, causing the blood vessels to go into spasm. And this is really involving the digital arteries that go to the fingers, and they are closed so that there's virtually no blood flow into the fingers. The patients can also experience a cyanotic appearance to the fingers, and this occurs when there is some blood flow to the fingers, and it's not entirely closed, and the fingers will have this cyanotic appearance as low blood flow pulls the oxygen out of the blood, making the fingers look cyanotic. This episodes then recover, and on this picture you see the hyperemia, or the recovery phase, where the fingers blush back to normal. My hand over here is the normal hand, and you can see the bright red color of the what's called the hyperemic phase, or the flush phase, on recovery from a Raynaud's event. Now, when the doctor sees a patient with Raynaud's, he can make a diagnosis just by the history. There's no greater value than doing a good history and physical examination, and you can ask the questions: are your fingers unusually sensitive to the cold? And if they are, do they change color when cold exposures? And if those colors are truly white and blue, or both, the doctor can make a diagnosis of Raynaud's. And there's no provocative tests such as dipping the hands in ice water or other such things that are much better than a good history like this. They can be pretty sure that the patient has Raynaud's if they answer these questions in a positive way. The prevalence of Raynaud's in the general population that is, individuals that have Raynaud's that are not necessarily related just to scleroderma, is extraordinarily high. It's 3 to 5% of the general population. It's more common in women than men. It is more common in young individuals than older individuals, but there's a great deal of variability based on gender, ethnicity, the climate that the individual lives in, and even occupation, and that there are some occupations that can provoke Raynaud's, such as the use of vibratory tools over a long period of time. Now, when you look at Raynaud's, there are some interesting clinical features that are important. First, Raynaud's generally spares the thumb, although in patients that have secondary forms of Raynaud's, such as scleroderma, the thumb can certainly be involved. And in fact, that's one of the clues that there may be an underlying disease process like scleroderma, and that patients that have uncomplicated Raynaud's rarely affect the thumb. The other thing about Raynaud's is that it, as I've shown in the original slide, is reversible. And this slide shows a sequence, and if you look at the little finger on the top of the slide, you'll see that over time, within about 15 minutes of rewarming after cold exposure, the event usually reverses back to normal. So a typical event lasts about 15 minutes after rewarming. Episodes that are not reversible are what we call critical ischemia. That is, the blood vessel goes into spasm, cannot open up, and that leads to tissue damage. A typical uncomplicated Raynaud's attack is reversible on rewarming. In addition, typical Raynaud's in an uncomplicated situation usually does not cause a pain. The presence of irreversible pallor and the presence of persistent pain is a warning that the finger is undergoing a distressful event, and could even be called the heart attack of the finger, as the blood vessel constriction is similar to coronary artery disease with spasm in the vessel. So we can summarize some of the things about Raynaud's and say that some of the fingers are worse than others. The index and middle are usually the worst, the thumb the least. Some patients will have one finger more often than the others, and in a terrible attack, all the fingers will be happen. White attacks are the more dangerous ones because there's no blood flow, and that can lead to this thing we call critical ischemia, which can lead to damage. Blue attacks are mainly in the superficial blood vessels that, as I'll describe in a minute, are the thermoregulatory vessels, or the vessels that control our body temperature. Low blood flow usually lasts 15 minutes after rewarming in uncomplicated Raynaud's, and painful attacks should warn the doctor and the patient that there's trouble, that needs medical attention. The feet are often forgotten. Patients will often say, I don't have Raynaud's in my feet, and then you see them in the clinic and you notice that their feet are cold, and they will have events before you with a cold exposure in the exam room. When the feet are involved, and in particular, if it's persistent and painful, you need to look closely to make sure that larger vessel disease is not present in the lower extremity. Older individuals, for example, can have atherosclerosis, or hardening of the arteries, that can complicate underlying Raynaud's phenomena and lead to critical ischemia and damage to the skin. Now let's look for a minute at what causes Raynaud's. This gentleman is in a cold environment, and one of the things that keeps his core temperature normal, 98.6, is the responses at the level of the skin. And so let's investigate for a minute the normal responses at the level of the skin. In the skin, we have two types of vascular supply. One supply is for nutrition, to bring nutrients to the skin to keep the skin alive. And the other system, which is unique to the skin, are vessels that we call thermoregulatory vessels. And these are blood vessels that are regulating the body core temperature. As you'll see, they're distributed like these dark blue areas on this cartoon, densely on the hands, feet, and head and neck. And you'll notice that if you get into the cold, these are the first areas that will be damaged with cold exposure. These are the areas that have the high density of the thermoregulatory vessels. Now, the way this works is that the skin has sensors in the skin that allow the skin to detect the temperature from the outside. And in fact, some things like peppers will also trigger these sensors off, and the patient will feel a hot sensation. This trigger then sends a message through the spinal column to the brain where there is a regulatory center in the hypothalamus which regulates the body responses to cold. And this response happens at the level of the skin in this unique little shunting-like system which shunts blood to and fro the skin at an extraordinary rapid rate and high perfusion. The way that it works is that this upper shunt is closed when the system is cold exposed. And it's closed in an exaggerated way through the sympathetic nervous system, the signal that comes from the hypothalamus. That forces blood to go into the deeper plexus, as you see here, and of course the skin will either look pale or blue, as shown on this picture. The patient under hot exposure, the shunt will open up and blood will gush to the surface and the skin will have a blushed appearance. And you'll see this radiator-like loss of heat from the body, allowing the core temperature to stay evenly at 98.6. Unlike frogs that equilibrate with the environment, then, individuals of the human race will regulate their temperature through this change in blood flow to the skin. In 1929, Sir Thomas Lewis, trying to figure out why there was individuals that had an exaggeration of this normal response to cold and heat, would develop Raynaud's phenomena. And after his clinical investigations, decided that it was indeed a defect at the level of the blood vessel, not at the level of the brain, not at the level of the neurotransmitters that came from the brain, but a defect in the blood vessels themselves. And researchers since then have shown that, again, it's not the level of the neurotransmitters that are coming from the brain to the blood vessels, but it's actually the response of the blood vessels themselves to the cold that seems to be abnormal. We have these receptors that are shown in this cartoon as a black circle that receive the neurotransmitters, and there's evidence that there's an upregulation or an increase in these receptors in patients that have primary or even secondary Raynaud's. And in fact, it's more complicated than that. There's evidence that with cold exposure to the skin, that it triggers a biological process that causes an increase in the numbers of these receptors so that the neurotransmitters from the brain see a lot more and cause an enhanced and exaggerated response to the cold. This enhancement of the cold receptors is under genetic control, and therefore we know that Raynaud's can run in families, although the exact genetic defect has not yet been discovered. The studies in Scleroderma, which we did years ago, taking biopsies from the skin, found that there was an increase in the alpha-2C receptor in patients with Scleroderma compared to normals, suggesting that the inflammation or the process in Scleroderma in part upregulated these receptors, making the blood vessel more reactive to cold temperatures. So this may be one of the defects causing problems in Scleroderma. Now again, historically, there was this gentleman, Dr. Hutchinson, who in 1886 realized that not all patients, like Dr. Raynaud said in his initial report, had problems with the Raynaud's. Some had benign Raynaud's. And he suggested that we characterize the Raynaud's into a group that he called primary and then a group that we call secondary. And in the literature, or if you read about this, you'll see a number of confusing terms. You'll hear the term Raynaud phenomena, that is, he doesn't possess the phenomena, Raynaud syndrome, idiopathic Raynaud's, and Raynaud's disease. These are all the similar term. In the United States, we use the term primary Raynaud's phenomena, and in Europe, they usually use the term Raynaud's disease for those patients that have Raynaud's without any underlying complicating disease such as Scleroderma. And for those individuals that have a secondary disease, we call it secondary Raynaud's phenomena. The primary Raynaud's patients tend to have vasospastic attacks that are triggered by cold and emotional stress, symmetrical on the right and left hand. Obviously, if you have one finger, you think about a secondary cause in that area, but in primary, it's symmetrical. There is no damage to the tissue or gangrene. If there is ulcerations or breakdown, you think of a secondary cause. The history and physical is otherwise normal. The small blood vessels that we'll look at in a minute are normal, and the laboratory data is negative in patients that have primary Raynaud's. Again, this can run in families. About 30% of patients that have Raynaud's will have another family member that has Raynaud's, and neither one of them are particularly sick. They just have this abnormality. So what are the clues that this may be an underlying disease like scleroderma? Well, the onset of age is important in that in patients that have primary Raynaud's, it starts usually in the teenage years, as you might expect, an inherited disorder that starts at a young age. While patients with scleroderma, it's an older age onset. There is this family history in primary Raynaud's. It's more severe in patients that have secondary patients that have secondary Raynaud's, and they have ischemic lesions. Primary patients do not. And of course, the examination and laboratory testing are normal. One of the things that we found in our view of our patients at the Scleroderma Center is that we looked at the average age of onset of Raynaud's. It was in the 40s. So patients that have the new onset of Raynaud's after the age of 30, we really begin to worry about a secondary connective tissue disease, and scleroderma leads the list. It's notable that the age that the patient was finally diagnosed was 5 years after the onset of the Raynaud's in our cohort of patients that came to us with scleroderma. And other symptoms took about 3 years before they started, with Raynaud's is often the first symptom in the onset of scleroderma. On the examination, there are obvious things to make us think of scleroderma. Puffy fingers, the early thickening of the skin with the inflammation that can occur. Edema that occurs in the limbs or fingers. These vascular dilatations of the capillaries that we call telangiectasia that you can see on the tongue of this individual. Pigmentary changes of the skin, darkening and lightening of the skin. Ischemic events in the fingers don't happen in primary Raynaud's, but they do often in scleroderma. Calcinosis, or clumps of calcium under the skin, are all too common. And one of the very early changes are these microvascular changes in the nail folds, which I'll show you on this next slide. The nail fold is a great place to look at the microcirculation. In this patient, you could see it with the naked eye. These are dilated capillaries as they come to the skin surface right at the fold of the nail. In scleroderma, you see areas of dropout, and you see these enlarged vessels that are a manifestation of the vascular disease that we see in scleroderma, the disturbance of these small blood vessels. When you look at it under the microscope, this is what a normal field of the nail fold capillaries look like. Here you see it right at the base of the nail. And here's what the scleroderma vascular changes are, these large, dilated, bizarre-appearing capillaries. And what's interesting is that if you take patients that come to you and they have Raynaud's alone without any other symptoms, and you look with a microscope and see the abnormal capillaries, and those individuals have a 20% chance, if that's the only thing going on, of developing scleroderma usually within a 2-year period of presentation. If they have abnormal capillaries and the presence of an autoantibody, such as an antibody to centromere, a marker of an autoimmune disease, those patients have an 80% chance of developing scleroderma within a 2-year period. Researchers, particularly in Italy, have been looking at the capillaries dynamically in patients that have scleroderma. And you can see in the early phase, the capillaries may look normal. Early changes are enlargement of capillary loops. Later, in an active phase, when the disease becomes clinically obvious to the doctor, you see dropout and enlargement of the capillaries. And then in a later stage, the capillaries look very bizarre. This is all pointing to the fact that there is vascular disturbance that is going on as a biological process in scleroderma, presenting as these microvascular changes and as the vascular disturbance that we call Raynaud's phenomenon. Now, we can see these vascular changes in other areas. You see them on the tips of the fingers. These are so-called telangiectasia when they're large enough to see, on the mucous membranes, such as the lips or tongue, and on the face. And we at Johns Hopkins did a study once where we looked at the number of telangiectasia that we could count and see on a patient on their fingers and face and body, and we correlated that with other vascular problems. And the one that we found was associated with this was the presence of pulmonary hypertension. And this slide shows the number of telangiectasia with the duration of the disease of scleroderma. The longer the disease, the more vascular telangiectasia you could see. And what I don't show on this slide is that there's a correlation with the number of vessels with the presence of underlying pulmonary hypertension or pulmonary vascular disease. So this is a bedside biomarker for the more systemic vascular changes that we see in the lung. We also know that these little blood vessels can dilate and be present in the wall of the gastrointestinal tract. And when they're in the wall of the gastrointestinal tract, you can see them when the doctor looks into the stomach when they do endoscopy. And you can see the streaks of these blood vessels that looks like the surface of a watermelon. And this has been called watermelon stomach. The importance of this is that these little blood vessels can break and bleed and lead to iron deficiency or persistent gastrointestinal bleeding, a complication in the subset of patients with scleroderma that can be bothersome. This can be treated by ablating those little blood vessels with laser therapy. Patients also get macrovascular events such as digital ulcers. And this is a slide of a patient that has an infarction of the skin due to a closure of the blood vessel and death of the skin due to lack of oxygen and blood supply. These kind of events are unfortunately too common. It's been described in this series of in up to 17% of patients, and some would say eventually about 50% of patients with scleroderma will develop digital ulcerations. These can be very small, and I'll show you some slides of different types of ulcers in a minute. The etiology for this is that not only are the blood vessels going through spasm that we see clinically as Raynaud's phenomena, but in scleroderma there's a vasculopathy where there is thickening of the wall of the blood vessel. Here's a cartoon showing what a normal blood vessel looks like with the lining and the wall being fairly thin. And here's a blood vessel where you see in scleroderma this thickening of what's called the intima layer. This leads to occlusion of major blood vessels. So you should see this is what the blood vessels should look like here, and here you see a digital artery that's occluded. When you look at the anatomy of this, there is thickening of this intimal wall to the point that the lumen is virtually disappears. And when that happens, and with cold exposure in Raynaud's, clotting can occur, no blood flow occurs, and the finger gets an ulceration. Here's an angiogram study looking at the comparison between what a normal finger's blood flow looks like, patients with rheumatoid arthritis in the middle, and patients with scleroderma, where you see very severe loss of major blood vessels, not just the tiny blood vessels that we were looking at as far as the capillaries, but larger blood vessels in the digits of the hand. Now, this reflects clinically into a number of different problems that patients with scleroderma have, and I'll just quickly show that, of course, some patients with Raynaud's never get ulcerations, and they just have Raynaud's. Others get a variety of type of skin lesions that can be small or catastrophic. And then there is poor blood supply to the skin that can lead to traumatic ulcerations. And, of course, we see some of the other more rare problems, which is digital pits, calcium under the skin, clubbing of the fingers, and inflammatory vascular disease that's very rare in scleroderma, more common in other of our rheumatic diseases. Now, some of these slides that are coming up are a little graphic, but I want to point out the kinds of problems that we deal with. This is a patient that has thickening of the skin, a contracture of the finger, and poor blood supply to the skin because of the vascular changes that I just showed you. And because of that, trauma to the knuckle leads to these breakdowns. These are called traumatic ulcers. These ulcers do not respond so well to vasodilation therapy, but you have to reduce the trauma, treat them if there are signs of secondary infection with antibiotics, and loving care topically. Eventually they'll heal with appropriate care. You can see that these can get very deep and could lead to significant problems, even finger loss if not taken care of properly. Small blood vessel disease leads to these erosive-like lesions that you see on this slide, tiny little punctate areas that are broken down. These two do not respond to vasoactive drugs as well as I would like, they often can get secondarily infected, and these kind of lesions need, again, topical care, antibiotic therapy, and an improvement in the big blood flow to the whole finger for them to heal, and they will heal with appropriate care. The more typical low blood flow Raynaud's-related digital ulcer are like this on the tip of the finger. Very painful, deep wounds that can be problematic. These too can lead to secondary infection and do respond, and we can reduce the number of these by the use of vasoactive drugs that I'll describe hopefully in a minute. If these are bigger blood vessels involved and deeper events can occur, and you can lose deep tissue. This is gangrene of the distal finger. Patient can either lose a tip of the finger, or if it goes down to the finger, they can unfortunately lose the whole finger. Now, the warning signs for this are, as I said earlier, pain. When we see a patient that has a reddened, inflamed area, but it's painful, then that's a sign of low blood flow and needs attention by the doctor immediately. Once the event occurs and the heart attack of the finger is over, then the inflammation, redness, and pain disappear, and now we have to manage the situation. And in this kind of terrible event, amputation of the finger may be necessary. There are individuals who are more likely to have catastrophic events. These are individuals that have limited scleroderma, the presence of anticentromere, the presence of this other marker, and they are more likely to have macrovascular disease. The lower extremity also can get ulcerations. When that occurs, we always have to look for bigger vessel disease that's upstream. Now, as I told you in the cartoon, the vascular disease is not limited to the circulation in the skin. We have the similar vascular problems that occur in the kidney. This presents as hypertension and can lead to renal damage. Happily, this is reversible with the use of ACE inhibitors. It also can lead to vascular changes in the lung, which can lead to pulmonary hypertension. And with that, there are now vasoactive drugs that are helping patients with this life-threatening complication of the vascular disease in scleroderma. When you look at these blood vessels, this is one in the kidney, you see this thickening of the wall of the blood vessel and narrowing and thrombosis that leads to these problems. I'm running out of time, but I'm going to quickly go through the pathogenesis. We think, what is wrong with the blood vessels? Why is this occurring? Well, as I've tried to point out, the problem is located in the small blood vessels, the capillaries, arterioles, and muscular arteries. It does not involve big arteries like those that are involved with cholesterol involvement of the large arteries coming off of the heart and the coronary vessels, but more the small blood vessels in the organs themselves. And there are three processes that are going on. There's vasospasm, or the Raynaud's. There's this thickening of the intima, or occlusion of the blood vessel, with fibrosis of the wall of the blood vessel, and then there's clotting and occlusion that lead to catastrophic events. And we know now that the reason this happens is that there's activation of cells that are called myofibroblasts in the wall of the blood vessel that are dumping out collagen and making the wall thicker and narrowing the wall. And this intimal proliferation leads to the vasculopathy that causes trouble. The underlying reason for this, we think, is the immune system dumping out various molecules called granzymes that can injure the blood vessel and trigger this pathway of fibrosis of the blood vessel wall. These granzymes dumped out by the immune system, we think, are coming from T cells, and they lead to injury to the blood vessel wall, and this injury upsets the normal balance so that constrictors are elevated, making the blood vessel more vasoconstrictive. Dilators are decreased, such as prostacyclin and nitric oxide, leading the blood vessel to be more constricting. These are the kinds of things that we can take advantage of, in that we have prostacyclin as a medication that we can increase. We have nitric oxide drugs that can increase nitric oxide to help vasodilate, and we have drugs to block endothelin to help with open the blood vessels up. The other thing that's been found is that we have stem cells that can come and repair blood vessels, and in scleroderma, these stem cells seem to be defective in terms of being worn out. There's less of them circulating to help heal blood vessels. Some feel that the stem cells may actually also turn into myofibroblasts and cause the blood vessel disease. And so what happens then is the T cells dump out granzymes. They lead to this thickening of the blood vessel, narrowing, and the troubles that leads to the vascular disease. And with that, the narrowing and the ischemic events occur that we see clinically. The vascular disease of scleroderma then is an underlying fundamental problem in scleroderma, and the clinical consequences are not only Raynaud's, digital ulcers, but also the problems that we have in the organs of the body. Now, in the last few minutes, I'm going to talk about management. These are the principles. We want to reduce the vasospasm, the vascular injury, and the occlusion in patients that have scleroderma and Raynaud's. And we want to do that in every of the organs that are involved. And each of the organs have a different system. The kidney responds to an ACE inhibitor. The lung responds basically the best is prostacyclines. And the fingers to a variety of vasodilators that are available to us. And for the vasospasm, we use vasodilators. For the underlying vascular disease that we showed on those slides, we have protective agents, and we are considering immunosuppressive therapy to be one of those. And for ischemia reperfusion, which is the injury that can occur, antioxidants can be helpful in increasing nitric oxide. For the blocking of the clotting, we want to block and inhibit platelets, and some, in an acute situation, will use blood thinners, such as anticoagulants. So this is just a list of what I said: oral vasodilators, intravenous prostaglandins, and protective agents that are available, including bosantins, statins, and antiplatelets such as aspirin, and antioxidant therapy that's available. Surgical operative procedures such as sympathectomy, blocking that pathway from the brain, can help reduce vasospasm. And if there's an occluded vessel that can be repaired, surgery can be helpful. And just as I'm coming toward the end here, we want to prevent the Raynaud's events by avoiding cold and stress. This is very important. There was a study done years ago that showed that patients with scleroderma were able to bring their blood flow back to normal despite the vascular disease in a warm environment. So there's nothing that is better for patients than staying in a warm environment. In a cold environment, you get this exaggerated decrease in flow, and these blood vessels are extremely sensitive. To show you an outline of what we do then is we stop the aggravating factors, including smoking and stress and trauma and cold. We start the calcium channel blocker as a vasodilator, and I usually use an aspirin to block platelets, and then I titrate the calcium channel blocker to the tolerated dose that helps. If patients still have Raynaud's that are problematic, particularly if there's ulcers, then we add a second agent, such as a phosphodiesterase inhibitor. The popular one is Viagra. Nitrates, such as topical nitrates, or in complicated cases, IV prostacyclin, not yet available as an oral drug, but soon to be. And then we add in the protective drugs. I'm not going to spend time, because I don't have it, to go over all the other options, but there are many little sites on the blood vessel that we can attack with various medications. I'll just mention one. Antidepressants block serotonin and can help in Raynaud's in some patients. This is a list for those that are interested and can go back and look of all the agents that we use for the treatment of Raynaud's phenomena and the vascular disease. One of the interesting ones now is Botox injection, not yet proven scientifically, but interesting. There also is a number of complementary things that have been done in terms of acupuncture, biofeedback, some of the biologics that are available in herbal medications. None of these things have unfortunately been proven to be effective, and when studied, they've been disappointing. The Botox injections have been used by the surgeons, and we have yet to prove that it's more effective than our more standard treatment, but I wanted to mention it so that you'll know about it. The final slides are that we have the vasodilators, but we also have drugs that help the underlying disease process. Statins can improve and decrease digital ulcers in patients with scleroderma. Prostacyclin or prostaglandins used are helpful. The tyrosine kinase inhibitors are available that are being tested to see if they can protect blood vessels from getting that fibrotic reaction. Bosantin is a drug that blocks that constrictor we call endothelin and helps blood vessels. And there are these new inhibitors called Rho kinase inhibitors that may be available soon. And a platelet therapy may block platelet activation and occlusion. And then finally, there is surgery where we cut the sympathetic nerves to block the sympathetic input to blood vessels and help the circulation to the fingers. Digital sympathectomy may only last for a while, but it can be helpful in a catastrophic event when there's an acute ischemia that's not reversible. If there is larger vessel disease, then we do have topical medication that can help with pain, and digital ulcers are treated with topical antibiotics and protective dressings. And then to end up, we do know that larger vessels can be involved, not only in the circulation of the hand that can be repaired by bypass surgery, but also in larger vessels on the extremities and the lower extremities. I should point out that these same vascular changes are occurring in the lung, in the vessels to the heart, in the vessels to the gut. And so when we treat the peripheral circulation, we are in fact treating all of the blood vessels in the body. And so I'll finish there and just say that the warm temperatures are the most important thing, along with the medications that we use and appropriate stress control. Thank you very much for having me discuss this important topic.
Great. Thank you, Fred. That was a fantastic presentation with really chock full of information. And we will have now about 15 minutes or so, and we will open it up for Q&A. And there have been a couple questions submitted. To anyone who'd like to submit a question, please do so in the chat window, and we'll do our best to field some of the most relevant and pressing questions. I just want to maybe start off with maybe one of my own, Fred, and just to talk a little bit about sort of basic management and the use of calcium channel blockers, which is, as I understand, it's really a foundation. Do you want to talk about maybe some of the complications which limit the ability to dose up in the calcium channel blockers, and what patients might need to be on the lookout for as they consider CCB therapy as a cornerstone of managing Raynaud's?
Yes, the calcium channel blockers were discovered back in the 1980s when they were put on the market to control blood pressure. And they work by relaxing the smooth muscle, and they're not specific for just digital arteries. And so one of the complications, of course, is lowering your blood pressure too much. And that needs to be considered. Most of the patients with a normal blood pressure actually tolerate the calcium channel blockers, even at the higher doses. The second major problem is edema, that is swelling in the lower extremities, and this can be quite problematic in a subset of patients. This occurs because you're opening the blood vessels, and the blood vessels leak fluid into the legs, and that may limit our ability to do this, to use these medications. The third major problem that we run into is effect on the GI tract, in that the GI tract is also a smooth muscle, so it can aggravate reflux disease. It can, in some patients, get constipation, and that's a major problem. If you lower the blood pressure too much, it can affect the circulation to the central nervous system, so lightheaded, dizziness. A small percentage of patients will actually get headaches from these medications. Interestingly, the calcium channel blockers are one of the leading treatments for migraine headaches, but paradoxically they can cause headaches. So those are the limiting things in the use of calcium channel blockers. I must say, however, that they will reduce the Raynaud's events by about 40% in scleroderma patients. They do reduce the number of digital ulcers. They're tolerated, and generally only about 5 to 10% of patients will end up having to stop them because of one of these complications that I've listed.
That's great. Maybe just along those same lines, if patients do end up adding another therapy, my understanding is that the PDE5s, inhibitors, Viagra's, and so forth have emerged as really some of the more popular ones. Do you have any advice to patients on how to think about, again, sort of the side effects and the challenges with dosing those drugs?
Yeah, so the phosphodiesterase inhibitors are a family, which the most popular ones by name are Viagra or Sildenafil. There are a few studies, case series now, that show that these agents have a benefit for Raynaud's. My own experience is they've been a little disappointing on their own for more complicated cases. They are certainly very effective for helping patients that have pulmonary hypertension, this same class of medications. Similarly to the calcium channel blockers, because they too are vasodilators, they can lower your blood pressure too much, and in particular when used in combination with a calcium channel blocker. They also can cause fluid retention. They can also cause hearing disturbances, visual disturbances, and my main problem with them is that they're a little disappointing in terms of being as potent as the enthusiasm is for them. My own use of these I often use them in conjunction with a calcium channel blocker when the calcium channel blocker is not working, or in those patients that can't tolerate a calcium channel blocker. You know, you can also not use a phosphodiesterase inhibitor if you're on nitrates, because both of them increase nitric oxide, which can cause an exaggerated lowering of the blood pressure. So you have to be cautious if you're using nitrates at the same time.
Thanks, Fred. There's been a number of questions about progression, and there's sort of two dimensions to that. I wonder if you could comment. Number one, does Raynaud's typically get worse over time in patients, and does that tend to correlate with a worsening of some of the systemic aspects of the disease? And I guess maybe as a second or third point to that, if you had Raynaud's in your fingers, should you be assuming that you're also having vasospasm in other organs, and would that then argue for more aggressive, basically, intervention?
The answer to the first question, in patients that don't have scleroderma, Raynaud's of the primary sort actually gets better with age. In patients that have scleroderma, Raynaud's generally becomes less of a problem with time in the majority of patients. And the reason for that, I think, is not only the medications, but there's an adjustment that many patients learn about the Raynaud's. They understand that stress and anxiety triggers it. They know that warm temperatures are very important. They learn that shifting temperatures, activity with banging the fingers and so forth can aggravate the Raynaud's. In other words, they acclimate to the triggers. They avoid those things such as even passive smoking and so forth. And so generally patients accommodate, and the Raynaud's does not, in the majority of patients, get progressively worse. However, there is a subset of patients where larger vessel disease is a problem. They tend to be those with limited scleroderma, those with a centromere antibody, and they can have recurrent problems that need aggressive intervention with the combination of medications that we have talked about. The issue that there is a little bit of a disconnect between the Raynaud's and internal organ involvement. Some studies suggest that when your Raynaud's is worse, that it suggests that there's internal organ involvement. Other studies don't show that. There's a disconnect. There are individuals that have nothing but serious Raynaud's and don't have any serious internal organ involvement. We did the initial study that I did when I got interested in scleroderma was to try to prove that Raynaud's occurred in the lung. And we took patients and induced Raynaud's and then studied the circulation in the lung. And we, and since then others, have not been able to show that Raynaud's occurs in the lung. There are studies that show that with cold exposure that you can get coronary vasospasm in patients with scleroderma. And there are studies that show that the scleroderma renal crisis, that is vasospasm in the kidney, seems to happen more commonly in the winter months and is reversed by ACE inhibitors that reverse vasospasm. So there may be vasospasm going on in other organ systems. It's not clear that it's triggered only by cold. There may be other things that trigger it off. It is true, however, that we think that the vascular medications that we use for Raynaud's, the vasodilators, help the internal organ and disease. For example, in France, they feel strongly that the calcium channel blockers prevent progressive heart disease by opening up the circulation to the heart, just like it does to the fingers. So I do think that the treatment for Raynaud's and the vascular disease in general parallel each other I'm not so sure that I could say that Raynaud's occurs in every organ every time you get a cold event.
Right. Maybe along those lines, Fred, do you have any advice about sort of a threshold for patients to start to think about when they might want to be on an ACE inhibitor or to be on immunosuppression or some of the other therapies which are really targeted to other organs aside from, if you will, the most obvious, which is the digits, if you will.
Yeah, so in the lecture, and I was going very quickly, but one of the points I tried to make is that each organ system has a unique way of regulating its blood flow. And so medications that help the kidney do not necessarily help the fingers, and vice versa. But the kidney vasospasm is very responsive to an ACE inhibitor. ACE inhibitors have been studied in Raynaud's, and they don't help Raynaud's. And so they should not be started if Raynaud's is the only problem. They also, in the old days, we used to think, well, let's start an ACE inhibitor and prevent a scleroderma renal crisis. But studies have shown that that's not the case. They do help once a renal event begins, but they don't necessarily prevent that from happening. And so the advice is not to use an ACE inhibitor unless there is evidence of hypertension or evidence of a renal crisis. For sure, then they're the #1 drug to use. In terms of immunosuppressive therapy, this is an area yet to be studied. The vasculature clearly is being damaged. The immune system is clearly a player in the damage of the tissues in scleroderma. There's been very few studies to look at whether or not immunosuppressive therapy will actually help the vascular disease, but it makes sense. And I think in the near future you'll be seeing such studies to try to clear whether that is an avenue that we should be going. In the meantime, we use immunosuppressive therapy for the more inflammatory phases of the disease, such as progressive skin disease, active lung disease that's causing fibrosis, active joint or muscle disease, and we generally don't use immunosuppressive therapy for Raynaud's alone. But the future may change that thought.
Great. Fred, we're getting a number of questions about patients. Sounds like they may have some very severe disease. Do you want to talk about maybe some of the threshold considerations for starting to consider surgical options or basically more aggressive options beyond oral medications?
For the vascular disease, the surgical indications are limited to the peripheral circulation. And those are individuals that have recurrent major ischemic events with evidence of a larger vessel involvement, such as the arteries in the arm or arteries in the palm of the hand, which can be demonstrated to be large enough that a bypass procedure can be done. And this is an uncommon situation. Unfortunately, larger vessels can be involved, but usually the ability to fix those by surgery is limited by the fact that smaller vessels where you could bypass and attach to are usually too small for the surgeon to do any procedure. Any kind of surgical approach of repairing blood vessels in the arm should be done only by experts in the area. I've seen all too often too aggressive approach made where problems occur. And more likely the medications that we talked about would be preferred. The other surgical approach, however, is a digital sympathectomy. I use a digital sympathectomy when medical therapy is not working in patients in particular that have a finger that's under distress or leading to potential ulceration or loss of digit. My sequence would be if a patient comes in and the finger is cold and won't respond to warming, then we start the vasodilator. I usually move quickly to IV therapy because we have that available at a place like Johns Hopkins. And if IV therapy with a prostaglandin is not opening and reversing the situation fairly quickly, then we move to a sympathectomy where the nerve going to the fingers is cut, and that sympathectomy can open the blood vessel in patients that do not have an obstructed mechanical problem in the vessel itself. So those two surgical options are used. And then, of course, there's all the surgical management of ulcerations that are present. These are usually wound care by a specialist. In our center, we use a plastic surgeon. Most of the time, we do not like to debride ulcers too much because the circulation in the skin surrounding a wound is limited, and we do a lot of just cleansing, making sure secondary infections are taken care of, and then doing grafting procedures on large wounds if necessary. Surgical options for the lung would be transplant procedures. There's no surgery to go in and fix blood vessels directly. When the lung has failed and the patient's not doing well in medical therapy, the option for lung transplant is present. For the GI tract, likewise, the only kind of surgical procedure is the laser therapy to ablate small vessels on the surface of the wall of the stomach. We cannot go in and fix arteries going to the GI tract. It's just not, they're not large enough to be repairable. So those would be the surgical approaches.
Thanks, Fred. Also, it sounds like some of the folks on the phone are having trouble when they get digital ulcers in just trying to accelerate their resolution. You know, certainly we've all had experiences of those getting infected and so forth and so on. Do you have some concrete recommendations about how to address those? Maybe, you know, antibiotic therapy that you think, you know, might be considered, and duration of antibiotic therapy as a way to, you know, help patients think about what they might want to consider?
Yeah, I think the number one thing to help ulcers get better is to do whatever we can to improve blood flow to the digit. If there's no blood going to a digit, the ulcer is going to have a hard time healing. As I also pointed out, it's important to distinguish the type of ulcer that we have. There are some ulcerations that are just caused by the damaged thickened skin, like those ulcers over the knuckles, that just don't respond to vasoactive medications as much as loving care to the ulcer itself. So it depends on what kind of ulcer it is to what kind of therapy will be the most effective. We do not, again, like to traumatize ulcers with debridement. We want to limit the debridement only to those areas that absolutely need to be cleaned up. So second, everything that you put on an ulcer can inhibit healing. And so if there's no need for antibiotics, then you don't want to use antibiotics. Sometimes just cleansing a wound with soap and water and then a little bit of Vaseline if there's an open wound is better than using antibiotic therapy that can inhibit healing. If there is infection, then there are two major things: cleansing again with soap and water, using topical antibiotics where they're necessary, and if there's evidence for spreading infection into the deeper tissues, systemic antibiotics are absolutely necessary. The type of dressing that is put on the wounds can make a difference. There are some of these colloid dressings. These are dressings that breathe rather than just bandages that occlude the wound. And these have been helpful to help speed up healing. Unfortunately, hyperbaric oxygen doesn't seem to help in situations like scleroderma. That just doesn't help. And then in addition to that, some of the acupuncture and some of those types of things just have not been potent enough to make a difference for scleroderma digital ulcers. We do not like to amputate fingers or lesions until it's absolutely necessary because patients can often heal fairly large wounds with appropriate care.
Fred, thank you very much, and I think that basically brings us to the end of our hour. I really want to reiterate thanks to you and for all that you've done, not only today for the hour, but in building out the Scleroderma Center at Johns Hopkins. Scleroderma community is growing both in its sophistication and its cohesiveness, and your leadership has been a tremendous component of that.
Well, likewise, and thank you and the Scleroderma Research Foundation. I think everybody needs to know what a huge impact the organization has had on giving support to centers like ours, and even more important, to investigators that have novel thinking about how to take care of this disease.
Thank you. To our listeners, when you do close out of the webinar window, please provide some feedback, which will be in a pop-up window in the form of a short survey. You can obviously, of course, can also email us via our website or call the office. And in closing, I would like to just reiterate that we do depend vitally on your support for our continued investment in the most promising research aimed at discovering new treatments and ultimately, of course, a cure for scleroderma. Please visit us online at www.sclerodermaresearch.org. Thank you very much. Bye-bye for now.
Bye.